In this episode, you will learn: consider CAB over ABCs. There's a growing shift toward prioritizing circulation first, especially in critically ill or trauma patients. Automatic CPR machines can relieve physical and cognitive load for EMS providers and staff in low-resource EDs. You may not need a central line. Large-bore peripheral IVs, rapid infusion catheters, and even IOs can deliver fluids and vasopressors as well or better than central venous catheters with fewer risks. Old is new again. Novel applications of existing treatments like push-dose vasopressin and transfusions of whole blood are transforming care, especially as EDs take on more ICU-level borders.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña.
Welcome back to EM Pulse.
Sarah, I think the vast majority of people who choose the emergency department as their work home are at least a little bit of an adrenaline junkie.
Yeah, that's true. I mean, it's a mental and physical workout to lead or participate in a resuscitation.
And it is an honor to be at that junction in life, and we all want to be the best that we can be in that moment.
And fortunately, the American Heart Association has created guidelines and updates to keep us at a minimum agreed state. If you can implement ACLS algorithms, you are maintaining the standard of care. But if you want to take it to the next level, there are some cool tips and tools that you may want to hear about.
To do this, we're joined by our colleague, Dr. David Leon. He is an assistant professor of emergency medicine and anesthesia at UC Davis.
So we've traditionally followed the ABC approach, airway-breathing-circulation in resuscitations. But there's a shift toward CAB, circulation first. Can you walk us through the rationale behind this change and how it's impacting resuscitation in the ED?
So for many years, there's kind of been a focus on airways first, traditionally taught ABCs, even by ATLS and many of the other traditional guidelines for resuscitation. And you can see this by the focus on a lot of societies looking at difficult airway algorithms, protocols being implemented and tested on. And that's in not only emergency medicine as well as anesthesia, but also surgery and even IM. But, more recently, there's been kind of a paradigm shift away from the anatomically difficult airway to more the physiologically difficult airway, especially as we get patients that are increasingly sick, especially when they present to us here in the ED. And there's also been increasing data on the risk of peri-intubation hypotension and how that's kind of associated with increased risk of cardiac arrest and other major markers of morbidity and poor outcomes. So, it makes sense to start thinking about patients really as physiologically difficult when they arrive. So even if they have an airway problem, you want to think first of their hemodynamics. And so when someone comes to you looking like they have an airway problem, there should actually be focused on the circulation first, because anything you do to them in order to take control of their airway, so to speak, you're going to be affecting their circulation. For example, any sedatives we give, that's always going to have some hemodynamic effects on us, regardless of how protective it is of blood pressure. That's eventually going to have some drop in your SVR, some drops on your blood pressure, because you're taking away that sympathetic drive that's keeping someone alive. So, along these thoughts about CAB starting to take over for ABC is also the focus. A lot in the pre-hospital realm is kind of the thought of controlling bleeding first before even looking at the airway. So through the use of things such as obviously tourniquets, but even beyond tourniquets, looking at AAJTs, which is aortic abdominal junctional tourniquets, and then other items such as pre-hospital use of REBOA. Even though the data is mixed there, it's still being thought and implemented in different EMS agencies. And then other ideas of just very focused control of bleeding rather than immediate intubation in the field and then control of the bleeding. There's focused hemostatic agents that are being put on there. There's focused wound packing that's being put out there. And then there's also the adjuncts that we're starting to think about, which is things such as TXA. As we all know, people love tranexamic acid. And then there's also now the expansion of pre-hospital blood products as more and more rigs, as we call them, EMS agencies are starting to get pre-hospital blood, not just red blood cells, but whole blood. There's focus on now just delivering and resuscitating the patient before addressing any airway issues. And I think the reason we haven't fully switched over to CAB yet is twofold. One, it's only starting to happen now, so we don't have the data to see, is CAB better? There's some early data that's out of the surgical literature, but, we like to have our own literature as EM.
Sure.
And I think the surgical literature really likes to focus on one, actually, that came out mostly from a lot of surgery attendings from my residency, Johns Hopkins. It was a retrospective analysis that compared ED intubations versus OR intubations for trauma patients. And basically, after risk adjustment, they saw that ED intubations were associated with increased odds of mortality and longer time in the ED, greater blood transfusion, and major complications. Obviously, this is pushing this from the surgical side to focus on CAB. But, without our own data to prove this, I think it won't be fully accepted yet about the CAB to ABCs.
David, do you know if there's a shift towards CAB in the non-trauma patients as well?
Less so, because while there is focused on this peri-intubation hypotension and cardiac arrest in non-trauma patients, there hasn't been quite so much pressure from, say, the pulmonary critical care physicians and hospitalists in general for CAB. Kind of follow-up to that is the CAB is recognized for most patients, but even there are times where ABC does take precedence over CAB if you notice that this patient has an impending airway and is hypoxic. Then that's where I think ABC still supplants, even in the trauma world. But in the non-trauma world, I'd say ABC is still the more prevalent matter.
I think that aligns with what we've been hearing for years and what we know from our own experiences, right? That peri-intubation time is such a perilous, dangerous procedure that we do together, right? And so optimizing everything has been that way for a long time. We've had hands-only CPR in the pre-hospital field and bystander CPR for a really long time. And there's been a large body of literature showing that good compressions is more important than putting a definitive airway in, of actually intubating. That's been there for a really long time as well. But important to note, David, what are your thoughts on the CPR machines that use in the emergency department? We see them come in on ambulances and patients that have arrest in the field. What are your thoughts of using those machines in the emergency department?
I really like this question because I experienced both sides of this coin. When I started residency, there really was no access to these automatic CPRs. There was a very few EMS agencies that had them. The classic manual compressions is all we had. And then coincidentally with COVID was the emergence of automatic CPRs. And kind of rapidly over really a 1 year time period, we converted from almost entirely manual compressions, at least in the ED, to automated CPRs. And almost every EMS agency that had at least greater than a 5-minute transport time, the patients arrived on automatic CPRs. We had the more well-researched device, which was called the Lucas, which for those interested there, Lucas stands for Lund University Cardiopulmonary Assist System. And there was mixed emotions and mixed thoughts when this was first implemented. Rightfully so, there was a lot of hesitation toward the beginning, through a combination of factors. One was the lack of just experience in using the device, their unfamiliarity from a physician standpoint, from the nursing standpoint, from the tech standpoint, from the EMS standpoint, all throughout. And then there was also several questions about the overall effectiveness of these devices. When it first implemented, there was kind of limited data. And then later on, when it was maybe 1 or 2 years into implementation, there was questions about the effectiveness of certain devices. I think where the data lies now, outcomes are relatively equivocal comparing automated CPR to mechanical CPR, at least in terms of outcomes. Now, where I think these automated CPR machines are beneficial is for those who have very long transport times, those who are resource limited in terms of staff limitations. Then it can certainly be beneficial, especially if you're in a rural area. You have a 45-minute transport time and you are performing those compressions all the way there. You have 2 people in that rig, then that one person's going to be very tired. I'm sure anyone who's done manual compressions knows that even a single round can leave you sweaty. I exercise. I'm preparing for a marathon, and even one round for me, and I'm really like, oh, who's ready to take over? It definitely is very beneficial in terms of the extended resuscitation ability that it provides.
So let's talk about access now. So what is the difference between, a peripheral IV, rapid infusion catheter, or central venous catheter? Talk us through that.
As someone who places IVs both ultrasound guided and landmark based, I've seen that determining what access is needed on a patient is almost an art. Most resuscitationists will always say bigger is better, but you always have to weigh the benefits of a large access versus the risk of placement of the access. Classically, we've been told that central lines are preferred, especially when vasopressors and large volumes are needed. But a few changes have emerged through literature and just through experience as EDs become a boarding center for ICU patients. One would be vasopressor data. So use of vasopressors through peripheral IVs was kind of dogma before. It was not something that we could do. Like if you did that, you only did in the most extreme settings. But now we have literature to show that vasopressors through a peripheral IV can be okay, at least for first couple of hours into resuscitating someone who's hypotensive. You want it through a larger bore peripheral IV. So basically you want a 20 gauge in the anticube or above into a large vessel that will likely cause extravasation and also less likely to cause any significant adverse outcomes that we worry about vasopressor extravasation. The second part about kind of the movement away from central lines to more peripheral lines is a lot of in vitro trials that have shown that flow rates through large bore peripheral IVs can be as fast, if not faster, than most of the central lines we place, other than slicks. The third point is a topic that I think most people aren't yet aware of, but is something that is available a lot in the trauma world and the OB world, is the emergence of RICs, which is rapid infusion catheters. So walking through, though, kind of like determining what access is needed, what is best to do, peripheral IVs will always be the most simple to place. If you can't place a peripheral IV within 90 seconds, many use that as a timer to initiate placement of an IO. IO, of course, has its limitations. That's both in infusion rates and labs that you can draw off this. But note that IOs are a good bridge to more reliable access, and I think they're underutilized at the moment.
David, can you define for us what is a rapid infusion catheter, and what would be some of the scenarios that you would want to use that for?
So a rapid infusion catheter is a peripherally placed catheter that is large bore, kind of almost to the size essentially of a slick, or as most people will know better as a cordis. And it provides the fastest flow rate of any catheter available currently. And the way it's placed is typically Seldinger technique, somewhat similar to a central line. And the way you do this is you can place 20 gauge or larger IV, then you place a wire through it, remove the existing peripheral IV, and then you put the RIC over it. And then you typically want to secure this well with suture because you want to treat it as a central line light. It's essentially can deliver you, better than cordis level volumes, but peripherally placed. So you don't have to worry about any of the risks that are associated with central line placement. To kind of summarize, RICs are short, fat catheters that you can upsize an existing peripheral catheter and deliver the fastest volume rates out there.
In adults, in somebody who needs fluids fast, and you can do pressures through it, yes?
Exactly, yes. So this is only really intended for adult populations. When it was first implemented, it was mostly in the kind of obstetrics world, primarily looking at postpartum hemorrhage, when someone had just delivered and they suddenly have massive exsanguination. That person is an extremis, and placement of a central line is pretty hard in that situation, whereas upsizing their existing peripheral IV to a RIC and then being able to deliver up to 500 cc's a minute really can save someone's life.
Okay, so give us some comparisons here. Like how fast can you go with a peripheral versus a RIC versus a central line?
So there's some data out there, a lot of in vitro data about the speeds. So note that anything I say is kind of given in that context. And the data out there pretty much looks at RIC delivering around 500 cc's a minute to the next best, which is a slick or a cordis, which is anywhere from around 400 to 350. The next best would be a 14 gauge. From there, 16 gauge. There is a 7.5 French introducer. From there, an 18 gauge. Notice we haven't even hit central line yet. Then next is an IO, specifically a humeral IO and pressure bagging.
Yeah.
And then finally, we've hit a 16 gauge central line, which is around maybe 180 cc's a minute in the most optimal conditions. So notice that like peripheral IVs far beat out central lines, most of our typical central lines that we place in the ED, which is not even a 16 gauge central line. Usually they're 18 gauge central lines. Note that all these numbers, though, are affected by several things. These are the most optimal numbers. Anything that we add to the system from whatever we're trying to deliver to the patient will slow down the flow rate. So things like needleless connectors or any J-loops, stopcocks will always bring down reductions in flow rates. And also the fluids we're delivering will be affected. So the numbers I gave you are also just for basic saline. For things such as blood, which is pretty viscous fluid, they'll go down quite a bit slower. And even the temperature of the fluid going through. So very cold blood is going to go way slower, at least 4 times the viscosity of saline. And it's going to go a lot slower, even through the most optimal catheter.
That's interesting. For another reason why the blood warmer is important. Okay, so now we have access. Are there new developments in vasopressors or hemostatic agents or other medication interventions that we should be aware of?
So globally, there haven't been too many new agents come out there. Just the same way when we look at antibiotics, there's really not too much new meds that are completely novel. That being said, the way we use our existing armamentarium is rapidly evolving. A good example of that is vasopressors in trauma, but also push-dose vasopressors for non-trauma critically injured patients. Vasopressors in trauma was kind of dogma, a never do, a never event. But relatively recently, vasopressors are starting to creep out into the trauma literature and the use in EDs, both in push-dose but also infusions. And this is for multiple reasons. One is we are in a blood shortage. The blood shortage is only getting worse. Our population of donors is primarily aged around 50 to 60 years old. So we have an aging donor pool, and we have a new donor pool that's not particularly interested in donating as much. So they're becoming harder to incentivize. So that's leading to a constant and worsening blood shortage. The only way we can really temporize this is vasopressors. And I say this because there's in the time of focusing on using blood for resuscitation, we also focused on the harms of excess crystalloid. Too much pasta water will ruin your vessels. Yeah. And, excess crystalloid leads to dilutional coagulopathy, can wreck the endothelial integrity, and it leads to worse outcomes. So what is someone left to do in the ED if they have no blood and they're told not to use crystalloids, but they're also been told not to use vasopressors? So now we've put into a state of considering vasopressors in these kind of critical situations. And luckily, there's essentially only one randomized control trial on vasopressors in trauma. All the rest of the data is essentially retrospective review. The one RCT, the average shock trial back in 2019, that used vasopressin as a way of helping maintain blood pressures in hemorrhaging trauma patients. And it is a positive trial. It showed basically equivocal outcomes to conventional treatment, but with reduced blood product usage. And interestingly enough, and kind of beyond the discussion today, but a decrease in TVT rates during their hospitalization. That being said, that's the only RCT out there about vasopressors and trauma. So it's still not widely accepted. So it's an ongoing discussion, but at least now it's a discussion with trauma surgery about, can we please use vasopressors to temporize this bleeding patient until you can get them to the OR. Looking kind of beyond that kind of non-trauma, push-dose vasopressors now, I think, are pretty well accepted in the EDs. There's the thought of expanding what can we push? Because, there's been a lot of talk about doing push-dose epinephrine, and push-dose phenylephrine is pretty well accepted, especially in the setting of kind of acutely temporizing a critically ill patient that just arrived. There is now literature in the anesthesia realm about push-dose other pressors. So push-dose vasopressin, but also push-dose norepinephrine. These are both items that I use routinely in the ORs and would love to use in the ED. I think this is kind of the next territory. These aren't new medications, but the way that they can be used in the ED is novel. A lot of the resuscitation tools we have there aren't new, but it's the way we're using them that is new. And a lot of that's focusing on earlier administration of these agents to the time of injury, the time of insult, the time of their illness. Example of that is something called lyophilized plasma or freeze-dried plasma. This is something all the way back from World War II that we kind of forgot, but now we're bringing back through things like the Preho-Philo trial and other trials like that, where we're trying to give plasma in the pre-hospital realm in lieu of more pasta water. And then there's other focus on things that we have had for decades in the hospital, things like using fibrinogen concentrate or even 4-factor PCC a lot earlier. These are all items that there is data showing potential use. Some of the early trials are equivocal, but there's still increasing discussion about how can we use these things. And then there's the big talk of the town is whole blood. Whole blood was what we used to give. Whole blood is, again, back to World War II. If you were out in the field, whole blood's what you had. The breakdown into competence didn't happen until decades later. But then that became the standard of what we gave patients with a severe hemorrhage. Whole blood is reemerging as a new tool, but really it's always been there. When someone donates, it's whole blood that they're giving. So it's interesting to see whole blood now being brought up as a new tool, even though it's what's in us. Lastly, I would say for vasopressors and kind of resuscitation tools, again, there's just different talks about how we use what we already have. There's some third-line vasopressors that have always been in the hospital, but now finally the ED has access to it. Things like hydroxycobalamin, methylene blue, other kind of more unique agents that to most EM physicians, they'd be like, huh? But with the advent of ICU boarding, we're getting to some patients who are not responding to our traditional vasopressors. Start them on norepinephrine, give them a little fluid, they'll be in the ICU in 2 hours. There are sometimes situations where it's 24 hours in and you still have that ICU patient sitting there and you are still responsible for this patient and they're no longer responding to norepinephrine. You started on epinephrine, they're still not responding to that. You're paging the ICU and they say, sorry, still no bed. What are you to do? You're now in discussion about more novel agents that, again, have traditionally been used in the cardiac ORs and ICUs, and now we are starting to use them in the ED.
All right, let's pause here.
For sure. That is a lot, and my ADHD brain is full.
Heard. Okay, good news is that there is more to come, so stay tuned for part 2 on resuscitation tips.
In the meantime, thank you to our department for making this podcast happen.
And thank you to OM Productions for being available for late night recordings like these.
Until next time, stay curious, stay inspired, and stay tuned.
The opinions shared on EM Pulse are those of our hosts and guests. They don't necessarily reflect the views of UC Davis Emergency Medicine, UC Davis Health, or any of their parent organizations.